What is it? Where is it? Who gets it? What's this dry stuff? What's the wet stuff? What does that mean? Well, how am I going to know if I'm getting it? What are my symptoms? What are the risk factors? And then what's the treatment? And is there anything I can do to prevent it? Really, people want to know what I can do to prevent it. So let's just start off with a healthy eye. Light comes in from the front, and it hits the cornea, the clear windshield, goes through your pupil, through that lens, which later in life becomes a cataract. Right dead center in the back of the eye is the macula. The inner lining of the back of the eye is called the retina. The macula is a special place of the retina, okay? That's the dead center. It's where our little photoreceptors are the most sensitive. They give us the ability to recognize a face or a number, read, drive, things like that. That macula in your eye and my eye is just a little bit bigger than the eraser on a number 2 pencil in diameter, if you want to think of how big is that little spot. And it probably has anywhere from 500 to 800,000 little photoreceptors in it. What happens? What is it? Well, we don't really know. If we knew, we could probably fix it, but we don't really know. What we see is we see breakdown of the layer that's underneath the retina, called the retinal pigment epithelium. And everybody just calls it RPE. It's easier to say, it's faster. But the RPE layer, the good way to think of it, it's the layer that nourishes the retina or the macula, and it's the layer that takes away the bad stuff. It takes away the byproducts of living, okay? And that RPE layer breaks down, and then those photoreceptors start to break down, and then unfortunately we lose vision. Here is a slide of a retina, or the inner part of the eye. Optic nerve in the center, blood vessels coming out of the optic nerve. The area out in here, peripheral retina, that little area that you can kind of see is a little bit darker right in the center, is your macula, okay? That's where it is. So when I look at your eye in exam and I hold a little lens up, I'm focusing back to the inner part of the eye, looking right. It's almost like looking into a basketball that you cut a little opening in, and you looked back to the back inside of the basketball, okay? Who gets it? Well, we don't really see it until people get middle age or above, and I just picked 50 or above. Definitely the risk increases with age. If you take 40-year-olds, 1% of the population maybe will have it. If you take 80-year-olds, there are studies that say 30% of the population will have some amount of macular degeneration, okay? Northern European, light-colored iris, light-colored eye, light-colored hair. So basically blonde hair, blue-eyed. Like people that get sunburn, more likely to develop macular degeneration. What's that make us think of? Possibly some UV light exposure issue. Family history definitely runs in families. No doubt about it, runs in families. Smoking, probably the only identifiable risk factor that we can change. And genetics, I put question marks behind it. Definitely genetics is involved, but now with the ability to look at genes, they're coming up with actual genes that are causing or are implicated in the problem. We're not to the point where we can do anything about that yet, but we're getting close to the point where we can say, this is the gene. Boy, if we could just change that, we could reverse the course or change the course in a younger person. The NIH says 1.7 million Americans today have significant macular degeneration. That means vision loss. That doesn't mean mild macular degeneration, which some of us in this room may have. That means significant vision loss. That number is expected to be over 3 million in 8 years from now. 1.5% of the population, maybe 10 to 20 or even 30, depending on the study you read. Here's an interesting number. 7 million people have high-risk characteristics in their macula, or that's an estimation of it. And it is the #1 cause of vision loss in adults greater than 60 years old. What are the symptoms? Early macular degeneration. I think somebody said back here they've been diagnosed with it. You may really not have any symptoms. You may be going around living life normal and not really know it, but you may have some little breakdown in your macula. Sometimes you may go, gosh, I don't see the paper, I don't read as well, and you just think, I don't have my glasses adjusted right. Or you're looking down the highway and you can't see quite as far on those signs. A lot of people come in with that, and it's very mild, okay? As it gets worse, more difficult to recognize somebody's face. You're at Kroger, you're at Walmart, somebody down the aisle's waving at you and you don't see them. And then bad spots, you get this just dead area in the center of the vision. It's just like somebody took a hole punch and punched out part of your retina. And distortion, this is a sign usually of the wet type occurring. Things that should look straight, like the edge of that window, get a big curve in them. Here's a demonstration of the dead spot. Somebody has just come up with a picture like that, and I copied it. And then the distortion. This is actually an Amsler grid. People with macular degeneration, we ask them to take a grid like this home and put it up on their refrigerator door or bathroom mirror and monitor it each day with the individual eyes. So there's two types, dry and wet. What is the dry stuff? Well, the dry stuff is also called atrophic, but we see these little drusen. Drusen in my exam are little yellow deposits in that RPE layer, okay? We don't know what they are. Some people say they're protein, some people say they're collagen, some people say they're lipid. What they probably are is the RPE not getting rid of the bad stuff, not being able to dispose of the wastes. And so we have some waste products building up, okay? Dry stuff tends to progress slowly, okay? And it accounts for the great majority of macular degeneration, somewhere between 70 to 90%, depending on what study you might read. One of the ways we try to diagnose it is with something called an OCT. That's a test we do in the clinic. OCT is like an ultrasound of the eye, except we're using light rays instead of sound rays. This is a picture of a retina. Now this layer that I'm pointing at, that's that retinal pigment epithelial layer. Right here, you see how it's humped up? That spot right in there is a large drusen, okay? And that's creating a problem in this person's vision because it happens to be right in the dead center of their macula. Picture of a normal OCT. Look at this RPE layer, real smooth, real symmetric. Might have some little waves in it, but that's very symmetric, smooth. This layer, where you see the little divot in it, that is actually the photoreceptor layer. We're getting down to seeing something with this test that you can't just go in a normal microscope and look at. You've got to get a really high-powered microscope, but that's a normal one. It's blown up a little bit. Now, what is wet? Well, in wet, almost always starts as dry. Very few people ever get wet just spontaneously. So we'll see drusen, we'll see the pigment break down, and then what happens is abnormal blood vessels grow from beneath that pigment epithelial layer, and they grow up through it. They bleed, and when they bleed, they start separating all those connections in there from those little nerve or those little photoreceptors to nerve fiber layers, and it's just like unplugging a electric cord from the socket. Once they don't make connections, they don't talk. And when they don't talk, no information gets back to your brain, okay? 10 to 30% of macular degeneration and the vision loss with wet stuff usually happens like that. People are like, oh, wow, what happened to my eye? That's when they're talking about that windowsill all of a sudden got this really big curve in it, and instead of them being able to see the words on the sign, all they can see is the sign, okay? And that usually happens pretty quickly. And by pretty quickly, I mean minutes, not days, but minutes to hours. When it bleeds, the blood leaks through. This is an actual patient, and on my exam, when I look in here, I just don't see the normal reflex, the normal sheen of the retina. There's a layer of fluid. This one has clear fluid, just like the serum or the white part of the blood that's seeped up through there, and it's already separating those layers. This person might see the big E on the chart if you've been in the eye clinic, but that's about it. Okay, it might not even see that. Go to the next slide. Here's one that's leaked blood in the white part. Look at that big. And when you can't see three-dimensional, but that will look like that's coming out at me or toward me on the exam. That's a lot of blood, and the white part of the blood that's gotten kind of hard. And so that's just destroyed this person's total macula. The slide I showed earlier with the clock face and the total defect of the clock face, that's what this person would see. Nothing in the center. They would They would look to the side. If they were sitting in front of you talking to you, they would turn their head to the side to look at you out of their kind of peripheral vision. They would use something what just is called eccentric fixation. Okay, but that's a dramatic wet macular degeneration. This is the actual OCT image of that person that had that big stuff in their macula. See how it's lifted the retina up? This is all blood in here. What they're showing you is a cross-section of the macula and all the layers. Retinal pigment epithelial layer right here, and they're showing you these little blood vessels growing up through that into the photoreceptor layer. And you get this blood underneath which starts separating these connections. So now you're in the clinic, and what's Tracy do to diagnose it? You've come in, diminished vision, what do? Okay? We look at you at that microscope that slides up in front of you, and we hold a little lens up in front of your eye. But basically it's an ophthalmoscopic exam. We can do the dye study if we need to, which you saw some pictures of, and we can do the OCT, which is like an ultrasound of your macula. But basically we're injecting dye in a vein, and it doesn't take but a few seconds for that dye to go from your vein to your eye. And so you've got your patient sitting in front of a camera that just goes just like a high-resolution camera taking a bunch of pictures. There's really no definitive treatment for dry macular degeneration. There has been one study. It was in the 90s to 2000s. They did for 10 years following a lot of patients. If you took a vitamin that was high in vitamin C, E, beta-carotenes, vitamin A, and zinc, those four things that in people who already had moderate macular degeneration, that means they had vision loss, 50% of them, it would slow the progression. Did not stop it, but it would slow the progression, okay? So they're not a cure, but it may slow it. Now, the study is not perfect, and we'll never get a study where we take a bunch of people and we follow them for 30 years and see if putting a vitamin actually helps with the people who don't have it. But I'll tell you, if macular degeneration was in my family, I'd be taking a vitamin. So vitamins, they're not a cure. There's nothing, we talk about today evidence-based medicine. There's no evidence-based medicine that I can tell anybody that doesn't have significant macular degeneration like yourself maybe who to take a vitamin. But I can tell you I would take one if it ran in my family. Now treating the wet macular degeneration. This is what we do now. There's going to be 4 or 5 more things that come up. We don't do them. Almost nobody does them. We inject drugs into the eye to cause those abnormal blood vessels to regress, to go away. And the names of the drug, this was the first one that came out, was Macugen, and then Lucentis and Avastin. They're the same thing just about. And then the latest one is called Eylea. Anti-VEGF, VEGF, that's the slang, is vascular endothelial growth factor. It's real important when you're in the wound and you're developing as a baby, okay? These drugs right here came from cancer drugs. This one, Avastin, was the start of it all. Avastin is a colon cancer drug. You take it systemically throughout your body. They don't inject it into the colon cancer. You take it as IV or a pill. Cancers need a lot of blood supply. They have a lot of actively growing new blood vessels. This stuff dries them up because it blocks a chemical in there called vascular endothelial growth factor. Somebody got smart and said, hey, we can do this in the eye, possibly. And they started studying it, and they go, wow, we can get this stuff to go away. Before we had these drugs, you walk in with wet macular degeneration, all we could tell you is pretty much, we're sorry. We didn't have stuff. With this treatment, most people almost get back to their baseline vision. And what I tell people is, say you were 20/50, you had dry macular degeneration and it caused you to lose a couple of lines of vision. All of a sudden you get wet and your vision goes to where you can't see the E. You get this treatment, you're very likely going to get back to almost that 20/50 driving vision again. Okay, so that's huge. That's miraculous. If you have wet macular degeneration and you need the injections, it's done in a clinic, or done in the clinic. You don't go to the operating room. And we put antibiotic drops on the eye. We put just a numbing gel, just a tube of numbing gel right inside your eyelids. Let it sit for 5 minutes. Come back with a needle, basically what the same needle would give you a flu shot with, and inject that medicine directly into the cavity of the eye. It sounds horrible, but if you go from not being able to see the big E on the chart, not being able to drive your car, to getting that vision back, people don't have any problem coming in once a month, once every 6 weeks, and dealing with the discomfort of that little injection. Okay, so what do? If you come in and somebody says you've got some early changes, they might or might not be macular degeneration, or you have early macular degeneration, you need to have this grid. You need to monitor your eyes individually every day to 2 days. Okay? Now, do you have to have the grid? Newspaper is perfectly fine. Magazine is perfectly fine. A book is perfectly fine. Anything that's got fine detail vision, straight lines, and columns. You do the same thing. What we do is you stare at the black dot. You need to use your bifocal, your near vision, and it takes 3 seconds to do it per eye. If you sit and stare at it, the eye surface will dry, and you'll get an artifactual, wow, there's distortion there. And then you'll come in and have to see me, and you'll sit in my clinic, and you'll get dilated, and I'm going to go no change, and you're like, dang, why'd I come? Okay? So 1 eye at a time, takes about 3 seconds per eye. If you notice a change, come back and do it 30 minutes later. Now, what if you're already like this? What I tell my patients is if you're already like this, you go ahead and draw that in with a little colored pencil or a little crayon. That way you can know if you're changing from your baseline. Okay, do people with macular degeneration become blind? They become legally blind. Legally blind's really kind of different than what layperson thinks of blind. They don't go lights out blind. Most people with severe macular degeneration can maintain independence. When we looked at that picture a while ago with the dead spot in the clock face, that's what they have, but they have full peripheral vision. Doesn't affect your peripheral vision. Those people in a known environment can usually get around, take care of themselves. They can make their own meals. They may not be able to get out the recipe and make out a real intricate meal because you can't see the fine detail, but stuff that you kind of already know how to do. Making the coffee. You can make your own coffee, okay? You have to learn to do it. It takes rehabilitation. Some of the reason why we're actually here and what World Services for the Blind is doing now, going into homes and working with people, okay? So then how can we also improve the quality of life? I want to be able to read a newspaper. I want to be able to read a book. There are devices. There are magnifiers. You can get real expensive, and you can buy TV screens that you slide a paper in, and it throws it up there, 400% magnified. The hassle with that is you can only see one word at a time, and it's pretty tough to read one word at a time. It gets really slow and really painful just on your brain to put up with that. Another big thing on these is like if you want to pay your own bills, okay? Everybody would like to be able to take care of their own personal, home. There are devices made to magnify your check and that have little spots in it where you're going to sign, where you're going to write an amount, okay, that help out. Those are helpful. There are devices out there and people that do that. Optometrists do a lot of low vision help too. Low vision specialists, sometimes that's not even a doctor. Sometimes that is a technician that's just learned a lot. Could be a nurse. And then occupational therapist, rehabilitation, that's somebody coming into the home and teaching ways to set in your stove, dots for 300, 350, different colored, stuff like that. Talking books, that's another thing. And when you have low vision, you can get the newspaper. I don't even know if there's a significant charge for it, but you can get that on audio. Okay, what do you need to do? At least when you're 40, get a baseline exam. The results of that exam tell us what to do. I see somebody at age 40, and they don't have macular degeneration. They don't have any other eye disease. Come back in 5 years, okay? When they hit 50, I tell them every 2 to 3 years. When they hit 60, I tell them we ought to see you every year, okay? And that may be a little bit over, but I'm pretty conservative about when to check their eyes, okay? Patients with risk factors, you have those drusen, you have little pigment changes or breakdown of that pigment layer. It's going to vary from seeing you once a year to even quicker or even more frequent than that. If it runs in your family, I'm going to have you back more frequently. And again, I just went back over 50 years plus, light-colored iris, family history, quit smoking, and hopefully we'll get to some genetic stuff. Again, right now it's about 1.7 million that have bad vision loss. It'll be 3 in the next 8 years, 3 million. Unfortunately, if we're seeing actually an increase in the slope of the number of people, these 7 million folks with high riskers, and our numbers may actually go up faster than just the population rate, because it's kind of seeming to be, this is actually getting worse for some reason, okay? Number one cause of vision loss in persons greater than 60.